Good morning. It's great to see that this conference is off to such a vigorous discussion. My name is Anna Tinter-Lyons. I'm the chair of the Department of Health, Evidence and Policy. And it's my great pleasure to introduce today's keynote speaker, Dr. Peter Orszag. Dr. Orszag was trained as an economist at Princeton University in the London School of Economics and currently holds numerous leadership functions at the Citigroup. Among others, he's their vice chairman of corporate and investment banking and the chairman of the Financial Strategy and Solutions Group. But perhaps more importantly for today's conference is that Dr. Orszag has a very extensive and distinguished career as a public policy leader. He was the director of the Office of Management and Budget under President Obama, and before that, the director of the Congressional Budget Office. He also held several senior positions in the Clinton administration at the Council of Economic Advisors and the National Economic Council. As such, Dr. Orszag has lived and, more importantly, shaped the political economy of healthcare reform. As a Board of Trustee member here, we are very fortunate that he brings his experience, his interests, and his intellect to Mount Sinai. For example, he's actively involved in stimulating new research in behavioral economics within the healthcare system. Today, he has graciously agreed to participate in this inaugural conference and share with us his many insights on the dynamics of healthcare spending and Medicare. Dr. Orszag, thank you very much for joining us.
First, let me just say to the students, I think it's absolutely terrific that you are enrolled in a program that is focused on improving value in healthcare, and I am glad there were appropriate comments that we're not doing enough to train the types of leaders that we're going to need in the future for the Healthcare 2.0, and I'm glad that you're actively enrolled in a program that will help rectify that problem. What I want to talk to you about today is that there's a raging debate about whether we're in the midst of big structural reform in healthcare or not, and I want to make the case that I believe we are, and that the data are already showing some of the leading indicators of that transformation. One of the most dramatic things that has happened over the past 5 years or so is a very substantial deceleration in the rate at which healthcare costs are increasing, pretty much across the board. So in private insurance, in Medicare, and in Medicaid. One of the themes that I'm going to be talking with you about this morning is I believe the single best indicator of structural change is what's happening in Medicare. And that is because the Medicaid changes will be significantly affected by eligibility and other rule changes at the state level and to some degree at the federal level. And private insurance will be affected both by the coverage expansion and, importantly, by the business cycle, neither of which affect Medicare. So there is a raging debate, and I'm going to go through this in a little bit more detail, about how much of this slowdown is due to the fact that we've experienced a significant period of economic weakness, and how much is not cyclical, how much is not due to the business cycle, and therefore at least holds the promise that it might be structural. Because after all, if it were all just the economy's weak, healthcare spending growth slows down, that will all reverse as the economy picks back up. Now here's one, for those of you who don't have a PhD in economics, here's one very simple way of looking at that problem. I'm going to go into this again in more detail, but there's no inherent reason to think that Medicare would be significantly affected by the business cycle. Most Medicare beneficiaries have some kind of wraparound coverage, either Medigap or employer-provided secondary insurance. And for most Medicare beneficiaries, the majority of their income comes from Social Security, which is protected against severe economic fluctuations. So both on the income side and on the copayment side, you wouldn't expect much business cycle influence on Medicare. And therefore, just look at this picture. Let's leave Medicaid to the side because there have been a lot of changes to the program that could affect trends there. Therefore, if it were all the business cycle that were driving this deceleration, you would not expect Medicare to slow down more than private insurance. The business cycle will affect private insurance, and yet look at the picture. What's happened is Medicare has decelerated more. There's a first kind of indicator that there might be something going on. Now, I should say there is a lot of skepticism, especially in the national press, which is slowly changing, that this deceleration is real, that it's not just the economy. So much so that very interesting experience in the first quarter of this year, there was an initial estimate from the Bureau of Economic Analysis, this is the blue line, that there was an explosion in healthcare spending in the first quarter of 2014. And you can see that blue line. So we've kind of had these pretty low rates of growth for the past few years. And then all of a sudden, the initial estimate of GDP had a very big spike associated with it. And consistent with the skepticism that I just mentioned, there were a whole series of newspaper articles saying the deceleration's over. So much for that, oh well. Now here's what's interesting about that. I can tell you the initial estimates from the Bureau of Economic Analysis for healthcare spending are based on what they call judgmental trend. That means they make the numbers up. They have no clue. And so I just looked around when that number came out and said, okay, well, let's look at some other things. What's happening? I'll show you some of these pictures in a second. What's happening to publicly traded available information, for example, from HCA, LifePoint, the big hospital insurance? What's happening to medical cost trend for publicly traded, and therefore the information's available, private insurance companies? What is happening to Medicare spending where the information is publicly available? What's happening to employment in healthcare? Because if you were going to see a spike in spending, you'd probably see some acceleration in hiring also. None of which was happening. So this is one of the rare examples where I actually decided to speak my mind and said, I think the GDP numbers are wrong. And I was immediately called a healthcare birther and other kinds of accusations. And lo and behold, when they went and they actually based in subsequent revisions, they actually based the numbers on actual data, shockingly. And the numbers that were revised actually showed a decline in healthcare spending in the first quarter of this year, which is the red line. This is quite striking because we did have a coverage expansion in the first quarter, not all of which showed up in the first quarter, admittedly. A lot of the utilization impact will come in the second and third quarters. Nonetheless, to have a decline in real healthcare spending at the same time that you're dramatically expanding coverage is a quite phenomenal outcome. So as I mentioned, you can see this deceleration in all sorts of different indicators. Now this may be bad news for some of the people in the room, but healthcare employment has decelerated significantly, especially relative to its historical trends, and we have not seen on a monthly basis any big pickup in the growth rate of overall employment. I would also note, and to the point that was made by Kathleen earlier, this overall average reflects very rapid growth in outpatient settings and flat to negative numbers in hospital employment itself. And I'm going to come back to the themes between inpatient and outpatient or hospital and non-hospital later on. So what do we know about what's been happening more recently than the first quarter? Because I mentioned the first quarter. What's been happening more recently? The answer is that the great deceleration, especially in Medicare, continues. So we have the data. In fact, next week we'll have the data for another month through August of 2014. But right now we have the data through July of 2014. Over the past, over the first 10 months of this fiscal year, Medicare spending was up a whopping 1.6% nominal. $7 billion. What that means is if you take out inflation and you take out beneficiary growth, Medicare spending on a real per beneficiary basis is declining. Okay, this is a hugely anomalous phenomenon historically. So what's behind that and what can we say about this and why do I think this indicates that something structural is happening? First, I want to come back to this crucial point about the business cycle. There is evidence that the business cycle affects commercial spending. This is a recent Health Affairs article that links across different areas of the United States, the change in the employment to population ratio to the change in spending per enrollee, and you do see a positive relationship. So If the employment to population ratio in a local area falls, spending per beneficiary, spending per enrollee will decline also. That's not too surprising because if you lose your job, if your income declines dramatically, if your employer is going through a hard time and pushes more co-payments onto you and so on and so forth, you're going to see an effect on utilization. Okay? And in fact, with regard to commercial insurance, so the slowdown that I showed at the beginning on those left bars for private insurance, you can pretty much explain most of it based on what's happened to the economy. So this same paper from Health Affairs takes projected spending growth if there were no change in the employment to population ratio. In other words, if we didn't experience the Great Recession. And you can see that basically if that were the economic environment on the blue line, there would have been very little change in spending growth in commercial insurance according to their analysis. The red line's what actually happened. The implication is that because the blue line's basically flat, that all of the deceleration in the commercial world is due to, or the vast majority of it, I should say, is due to the economy. But now let's contrast that with Medicare. You may not be able to run regressions in your head, but I can tell you, based on that scatter plot, that the correlation there is 0. So there is no connection across states between changes in the employment to population ratio or changes in the unemployment rate and changes in Medicare spending. This is a much different picture than the picture for commercial insurance. And this comes back to my point, this is exactly what we'd expect, which is there is no cyclical relationship between Medicare spending and the economy, even at the local level. And this is consistent with, there have been all these, I think these are not the high point of economics or econometrics. I think these are actually very poorly done studies, but there have been a lot of studies that have been trying to take basically 30 or 40 years of national level data and explain how much of the slowdown in healthcare spending that we've been experiencing is due to the economy just by relating top line growth in healthcare spending to lagged GDP growth or lagged unemployment. You should immediately be skeptical of these things, by the way, because the lags that they include are typically 6 or 7 years. So what that's saying is a recession hits and the effect on healthcare spending lasts for 6 or 7 years later, it's still having an effect. I find that kind of hard to believe. The other reason that you should be skeptical of these things is I've actually played with the data, and so if you use 5 years or 7 years, or if you change the sample period from 1972 to start in 1974, small changes, you get the percentage that's due to the economy to move from approximately, they typically will go out and say it's 77% due to the economy, and that sounds really precise. But you can make tiny little changes in the specification or the sample period, and I can move that 77% to somewhere between minus 50% and 200%. Okay, that should immediately raise questions in your mind about the rigor of these things. Nonetheless, those people who do this, there's a recent Brookings paper, applied it specifically not to total healthcare spending, but to Medicare spending. And what's interesting about that is, again, the expected Medicare spending based on this very poorly done econometrics model, in my opinion, suggests that Medicare spending basically should not have slowed down. And yet the blue line shows that it did. Again, strong evidence that something is happening in Medicare that has nothing to do with the economy. All right, so I think hopefully I've convinced you that Medicare does, and by the way, the Congressional Budget Office, which I used to run, has also done a more formal econometric model that also suggests that the economy has very little to do with Medicare spending. So I hope that combination of factoids convinces you that the slowdown in Medicare is not due to the economy. That doesn't necessarily mean it will continue, however. So this is a graph of per beneficiary spending in Medicare. You can see the recent slowdown, but you'll also notice another interesting data point, which is in the late 1990s, we also had a deceleration. Also not due to the economy, because as you remember, the economy was booming in the late 1990s, perhaps artificially, but nonetheless booming. So the question then becomes, that got reversed. We see that Medicare spending picked back up. Will the same thing happen now? And there is no guarantee that it won't, but there is a very important difference between the deceleration then and the deceleration now. The deceleration then was due almost entirely to price reductions. That is, reimbursement rates were cut as part of the balanced budget amendments agreements of the late 1990s. This is a slowdown in spending that is basically achieved through the blunt approach of just slashing how much you pay providers. And most of the evidence, not all, but most of the evidence suggests that's a very effective strategy if you want to slow down growth in total spending for a couple years, but it's not a particularly sustainable approach, especially in an environment in which budget surpluses are arising and people are saying, well, why are we doing all of this in the first place? That contrasts very importantly with what's happening recently. So this is actually the analysis from the Congressional Budget Office that I had mentioned before. What they did is they compared 2007 to 2010 in Medicare to 2000 to 2005. They found that there was a 320 basis points, that is 3.2 percentage point reduction in the growth rate of per beneficiary spending in Medicare. And here's what's interesting. First of all, I had said that the economy was not a factor, and you can see the financial crisis and economic downturn accounts for a whopping 0.0 percentage points of that 320 basis point slowdown. Demographics explain a little bit. The point I wanted, a really important point though, is in the circle, the change in the payment rate, especially in the 2007 to 2010 period, explains almost none of the slowdown. Almost all of it is on a demographically adjusted utilization deceleration basis. In other words, it's not that we are paying, or at least during this period, that we were paying people a lot less. It's that there was less stuff done to each 67-year-old or each 69-year-old in Medicare. I shouldn't have said less stuff done. The rate at which the stuff was done was increasing at a slower rate. That is the big change, and that's a fundamentally different dynamic than what happened in the late 1990s. Now, why is this important? It's important for a whole variety of reasons, but one of the reasons that it's important, that's near and dear to my heart because of my previous jobs at least, is it would have a truly massive effect on the nation's long-term fiscal picture if it were to continue. So most of the official projections, which are the basis for, oh my God, we're falling off, our lives are about to blow up because our nation is on a completely unsustainable fiscal course and it's going to be really bad and your kids are screwed and all that kind of stuff that's always in every editorial page, that is based on the official projections, which kind of sort of, it's not quite, but kind of sort of, are based on the average growth rate per beneficiary over the past 20 or 30 years. And then because that becomes implausibly large, they artificially slow that down in a completely arbitrary way to some other number, but it's still fundamentally based on the past 20 or 30 years in terms of cost per beneficiary, and then you combine that with the demographics and you get total spending. And you get that blue line, which is the basis for all the histrionic editorials. Just hypothetically, and I'm not saying this will happen, but hypothetically, what if the future is not like the past 20 or 30 years, but it's like the past 5 years? You get the bottom dotted line. This is an illustration of both how important spending per beneficiary is to the future of Medicare, and also how much the slowdown, how big the slowdown has been. Effectively, if we were able to propagate into the future what has actually happened over the past 5 years, then despite the retirement of the baby boomers, effectively, you see a little bump from the baby boomers, but barely any. Effectively, Medicare spending as a share of the economy, instead of rising rapidly and being the basis of kind of the meltdown in our fiscal gap, is flat. And that in turn means that the entire long-term, everything you think you know about the nation's long-term fiscal gap would be wrong if you all are able to achieve in the future what's actually happened over the past 5 years. Very big deal. And it's a very big deal for state governments. It's a very big deal for workers' take-home pay. It's a very big deal along a whole variety of dimensions. So this is of first-order importance in a whole variety of ways. The question then is, what's causing this? And I believe that I do believe it's structural, and I subscribe to the aircraft carrier theory of what's happening, which is that currently maybe 10% of payments are not fee-for-service or value-based in some way nationally, that providers, including the leadership here at Mount Sinai, believe that that payment system is evolving rapidly. And if you go out and ask hospital executives, often you get 30, 40, 50% of payments expected to be value-based within 3 to 5 years. I'm not sure the system will actually move that fast, but we'll see. And similar to an aircraft carrier, if you think you need to head in that direction, you got to start turning the aircraft carrier today. That's then being reinforced by the fact that the system is digitizing pretty rapidly. And so all of a sudden you have a lot more information to manage utilization and value in a way that was not possible before because you didn't have that information. And then finally, this is not relevant for Medicare, but in the employer world, dramatic increase in the information that's being provided to consumers, in the cost sharing that's being imposed on consumers. Effectively, we're moving towards a defined contribution model for healthcare, just like we did for pensions among current employees. So let's just go through this a little bit more. Middle chart there, the one that's in the box. As I mentioned, within 3 years, this was a survey that Aetna put up at its Investor Day. 49% of facility revenue projected to be derived from value-based payments within 3 years. That is a huge change if it were to occur. And my point is, even there is a risk in that a lot of things are being done, in my opinion, based on that expectation. It's not the current reality. If the expectations are not realized, we're going to have a big problem. So there's a gap now between reality and expectation, and policy better step in to fill that gap, or else a lot of the progress that we've been making will be reversed or not happen. And one vignette, a good example of this, is what's been happening to readmissions. So there was a great question before about quality. I don't think anyone would argue that 20% readmission rates is consistent with the highest quality, that all of these are medically necessary, especially because the best performers in the country are often at a third or a quarter of that. And so this is a good example of, if we can, in general, not always perfectly, but in general, if we can reduce readmissions, presumably that's a situation in which we're both saving cost and improving the quality of people's lives by keeping them out of the hospital. And there has been a noticeable decline in readmission rates under Medicare, and including at Mount Sinai. So Mount Sinai provides a great example of the aircraft carrier theory. So we have the PAC program to reduce readmissions at Mount Sinai that will target very high readmission risk patients, put a team of social workers and others on them. Right now, despite the penalty for high readmission rates, and I know there are others in the room who know the data better than that, it is my impression that that's a money loser for Mount Sinai, because in general, you're still getting paid based on each readmitted patient. So even though you avoid the readmission penalty, that's still a net loser. And then the question becomes, why is Mount Sinai doing this? And one answer, of course, is benevolence, because we believe in, it's a good thing for the world. But another more important answer is that the leadership at Mount Sinai believes that within a few years, these sorts of programs will turn from being net financial losers to big net financial winners, because as we move to value-based payments, the incentives completely change. If you are presented with a capitated payment, if you become a Medicare Advantage plan yourself, if you are in a negotiated arrangement with a private insurance company that either has a bundle all the way through the post-discharge time, and therefore avoided readmissions are out of your bottom line, if you're an ACO structure, all of those structures mean that your incentives are totally flipped on their head. Each avoided readmission is now a benefit to your bottom line because you avoid the costs associated with that readmission, as opposed to each avoided readmission being a net loss because you lose the revenue associated with it. There's also, I think, a huge amount of opportunity in narrowing clinical variation that's unwarranted, that's not medically necessary. In my day job at Citi, some of the highest valuations that we're seeing are on firms that play the big data game and on a risk-adjusted basis, and I'll come back to the risk adjustment because that's obviously crucial, on a risk-adjusted basis, help hospitals and other providers identify sources of clinical variation and then try to narrow them. This is an example from Mass General. This is outpatient images, so CAT scans, MRIs, so on and so forth. I find this truly astonishing because these data are ostensibly risk-adjusted. And what you see is, and by the way, this happens year after year after year, so it's not just random noise. There are some doctors who are just ordering a lot more tests than other doctors. And if you looked up at the 90th percentile, these are individual docs, and if you look up at the 90th percentile, those folks are ordering sometimes 5, 10 times as many images per 10,000 patients or per 100 patients as other doctors. What did they do? They put in an order entry system, so you have to, with some clinical decision support, you have to override the system if you want to order the image and it doesn't look warranted. You can still do it, but but there's a little effort required. And more importantly, they actually sat the docs down and had benchmarking discussions. So they'd sit the doc down up at the 95th percentile and say, do you realize how high you are? And astonishingly, time after time, docs would say, I just didn't realize I had drifted so far. This would have been very difficult to do 10 or 15 years ago because the docs would say you're not risk adjusting right. You can't just use claims data, your risk adjustment's bogus. Using clinical data to help do the risk adjustment is crucial to create face validity to accept this kind of thing, and this is exploding also. I think there's massive opportunity for more efficiency from that. So let me then end on this question, which comes back a little bit to the quality one, which is all of this a good thing, and is there opportunity for improving value in healthcare without harming, can we constrain costs without harming quality? And I think the overwhelming or the resounding answer to that is yes. One has to be careful, but I want to just go through the most recent evidence on why I think there is massive opportunity. Now, it's well known, and I know this is not popular at many academic medical centers, including Mount Sinai, but there's a but coming, so just hold on with me here, okay? Just stay with me. So the Dartmouth folks and Jack Wenberg, et cetera, have spent their entire career documenting significant variations in cost per beneficiary across different parts of the United States. Whenever I put up the graph, I have to note immediately, I did not make this graph, so do not read into any political ramifications of the higher spending regions being red instead of blue. Nothing like that. The point just is there's a lot of variation in cost per beneficiary across different parts of the United States, even ostensibly when they try to adjust for risk and demographics, okay? Now, that perspective strongly suggests that there's a lot of opportunity for improving value in healthcare because there's no association between the higher spending regions and quality. However, there has been a variety of challenges to those data, not even on the kind of, are you doing the risk adjustment well? One of the most compelling challenges to what I'll call the Dartmouth thesis was a study by Doyle et al., economists at MIT, that did a very clever thing. It actually used New York state data, examined hospital referral regions, ambulance referral regions, and noted that basically which hospital you wind up at will depend on often which side of the line, where the ambulance referral region is, which side of the line you happen to live on. And it's almost a randomized thing because there's no reason to think that the lines were drawn in a particularly biased way. And so what they did is they studied based on the address at discharge. They used that as an instrument for which hospital you wound up at, and then studied the connection between spending at the hospital when you showed up at, and I want to emphasize this is ER admits and ER visits only, when you showed up at the hospital and 1 year mortality afterwards. And it found that up in the majority of hospitals, there was a little bit of tailing off at the very end, but for the majority of hospitals, if you went to a higher cost hospital, you had a lower mortality rate. That is a very strong challenge, especially given the quality of the way that they did the analysis to what I'll call the Dartmouth hypothesis. However, as I mentioned before, it was only for ERs. And so then the question becomes, what about all the other stuff? And there's been more work now done on what I'll call the national level Dartmouth variation, including an Institute of Medicine study a year or two ago, which strongly suggests that most of that variation, the vast majority of the variation that I saw in the first graph, is post-acute. So it's not ER, it's not inpatient, it's what happens after the fact. And you can see that 73% of the variation across the country that Jack Wenberg and others have kind of been focused on comes from post-acute care. In other words, if there were no variation in post-acute care, there would be a 73% reduction in the variance across the country, which is the vast bulk of what's going on. Now here's what's also interesting. Doyle et al., oh, I don't have a graph. Anyway, I'll tell you. Doyle et al. Have now updated their study, and they use exactly the same estimation methodology based on ambulance referral regions, and they then study all-in cost, acute and post-acute, and not just the ER piece of it. And what they find is the negative correlation, that is higher spending regions, lower mortality rates for the acute piece, negative correlation, that is higher spending, or at least hospital systems, post-acute, higher mortality rates. When you add the two together, the Dartmouth result is reestablished. There's no connection between total spending and overall mortality 1 year out. And that's because of this difference between the acute and the post-acute space, and it lines up nicely with what the Institute of Medicine itself is finding. Now, what's interesting about that is, I think, and that obviously leads to very important suggestions, which is if you want to narrow this variation, if you want to try to wring more efficiency out of the system, you've really got to focus on what's happening post-acute care. That ties back into the readmission rates. I would say that's not all. I mean, that's a lot of what's going on. But this, coming back to the point about, for example, the imaging, there's a lot of variation even within the four walls of what's happening, or at least what's being ordered within a hospital, that also suggests that there are possible, and I agree that we have to be careful about how we do this, but possible improvements in quality, that we can constrain costs without harming quality. And that opens up a massive opportunity to achieve what I hope you all will help to achieve, which is a continuation of this cost trend, slower cost trend, with massive benefits for the economy without harming outcomes, and possibly even improving them. So I think Arthur had said it's a very exciting time to be in healthcare. I couldn't agree more. And I believe we're starting to see the aircraft carrier turning, and it's through programs like this that we'll be able to kind of keep it on the new course. Thank you very much. Do you want me to take some questions? I can do it. Yeah, if we have questions, I'd be delighted to answer some of them.
So you mentioned a significant variation in post-acute care services, but Kathleen presented some, I'm sorry. You mentioned the variation in post-acute care services and the opportunity that's there, and Kathleen had presented some information on who was at risk in terms of penalties with the reform, and hospitals clearly seem to be the one taking the highest hit in terms of that. There seems to be something slightly contrarian about that, right? A huge opportunity in the post-acute care service world and variation, and yet the hospitals seem to be the ones most at risk for a lot of the financial penalties. How do you see that playing out? Is there some rebalancing? What's the political policy around that?
So it's a great question. I mean, I think let's take the two leading alternative payment ideas, either bundling or an ACO type structure. Either at the federal level or through commercial insurance, or at the state level through DISREP. Similar concepts. In both cases, someone, and it's not always the hospital, often a lot of ACOs are physician groups, but someone is taking, and sometimes, by the way, I want to come back to taking too much risk, but taking the risk of all that post-acute care. And the key then is, can you actually manage it any better? And so, I think there are two things that should be separated. One is the payment reductions for hospitals through DISH and what have you. And the second is that someone, whether it's the medical home or the physician group or a hospital, someone is going to be bearing the all-in cost and risk associated with a patient who is traditionally not, traditionally that's the insurance company, but is now going to be a provider of some form. And what that in turn is doing is leading to lots of different discussions. So one of the motivations, it wasn't the only motivation, but one of the motivations for the Continuum merger was consistent with the motivation of many other providers now, before we even get to the post-acute space, that if you're out in the middle of the country and you're a 200-bed hospital, and all of a sudden you're kind of being moved towards a capitated system, you're effectively an insurance company. And yet, you're not at minimum efficient scale to be an insurance company. So what do you do in that situation? You've got basically two options. You can either try to expand scale, either combine with some other hospital and get to minimum efficient scale, or you can try to come up with some creative arrangement with the payer, with some insurance company, to take some of the tail risk off of your back. And both things are happening at a quite dramatic pace. In the first case, the desire for consolidation, which, by the way, has been an issue, concentration in local hospital markets, not New York, it's a very competitive market, but outside of big cities, has been a growing problem. If you look at the traditional antitrust measures like the Herfindahl Index of concentration in local hospital markets, it's been rising, and there's been a very significant attempt to have it rise further, in part motivated by what I was just saying, and yet the antitrust rules basically have not been fully updated to reflect that motivation. In fact, there was a recent case, it was fascinating, in which the judge said, I understand, in fact, discovery and all the evidence suggests you seem to be motivated by this, value-based thing, and that's great, and you want to coordinate care with your post-acute and blah, blah, blah. Nonetheless, you violate the the traditional antitrust thing, so not going to happen. So there's kind of one set of issues there. The second approach of sharing risk with payers, every major payer in the country, from Aetna to Humana to Cigna to United Health, they are all trying to pitch themselves as being the partner of choice to providers as they move through this valley of death of a mixed payment system towards the other side of more value-based, and we'll share the risk with you. But fundamentally, regardless of how those arrangements are made, you're absolutely right, which is someone is taking on the risk of, the post-acute care component without having full control over it. Another way of putting it is estimates of the ACOs suggest that somewhere between 20 and 40% of healthcare spend by ACO members occurs outside the four walls of the ACO. So if you're taking on 100%, you're taking on responsibility for 100% of the costs, and yet 20 to 40% is not under your rubric, what do you do? And I think the two key questions as we move towards some of these alternative payment systems, three quick questions. One is, are hospital systems taking on more risk than they can handle? Second, what happens with the leakage, if you will, outside the four walls? And the third thing is the attribution rules, which is, how do I know that you're actually my patient for these purposes when patients are seeing different providers and there's churn? And all three problems are pretty big problems. Let's go back here.
The deceleration that you described has taken place over the last 4 or 5 years. But when you then posited what were the reasons for this, what were the potential structural changes, most of the things you spoke about they're theoretically things that will help. They're things that are taking place perhaps now, or we anticipate they'll take place in the future. But they're not terribly convincing for changes that started several years ago. And I know you talked about the aircraft carrier, but the aircraft carrier stuff is taking place now or in the last 2-3 years. Can you expand a little more on why you think these changes started to take place 4 or 5 years ago?
Yes, it's a great question. So, what was driving? Let's go back to this this chart. Well, we can even start here. This one actually conforms to aircraft carrier fairly well, because the declines really start, 2012-ish. You're well in the middle of the confidence interval before that. But with regard to the total spend, let me go back to that. Whatever. I'll speak to it. The question is, why was spending in 2009 or 2010 decelerating in Medicare? And I think part of that, frankly, was just that we saw this during the Clinton episode in the early 90s also. I think part of that was simply just the, for lack of a better term, scare factor of reforms on the table. We need to, it's a little less aircraft carrier because you don't know exactly where things are heading, but a little bit more, we just need to kind of keep our heads down and not get, let me put it this way, if cost growth were dramatically rapid in 2009, I think many people appreciated that that would mean that the WAC to payment rates would have been even more, because it's not atypical for MedPAC, for example, basically just to look each year at what's growing really fast and say, let's whack that in the whack-a-mole story. So I think the 2009-10 period is a little different than the 2012 on period. 2009, I think, is mostly just let's keep our head down and hope not too much happens. Let's go right next to you. Okay.
I was
Okay.
the chief economist of the World Bank for a number of years, and we saw hundreds of health reforms with radical payment shifts. And the typical story that we saw really was that the providers really caught up very quickly. They learned the game and got ahead of the policymakers, quite frankly. So, I mean, putting on both of your hats as a previous policymaker and now also on the hospital side, isn't the likely scenario in the medium term that the system is really going to adjust to this, and this is an opportunity? It's not, you know, we're scared of the risks, but isn't this really an opportunity actually for the hospital sector?
Yeah. So there are two ways that providers typically, or that things like this get undone. One is political backlash, so we'll call that the managed care experience of the 1990s in the commercial space, that individuals, you know, the political environment creates such a backlash that the effort is undone. And the second is gaming, upcoding of DRGs and what have you, sort of behavioral response to whatever set of incentives are in place by the providers. I would say two things. One thing is what's different this time relative to managed care is not only that hopefully we'll have more information to make sure that it's not just cost-driven, but it's actually value-driven, and there's a very important difference between the two of them. But just as importantly, the locus of risk is now, or the decision maker is moving towards the provider. It is a much different thing for a patient to be told by an insurance company, we're not covering this, than to be told by the doctor, by his or her doctor, I don't think you need that. That's a much different experience. Now, the latter is not perfect, and indeed, one of the risks in all of this is that eventually people are going to say, well, wait a minute, are you telling me I don't need that because if I did get it, you'd get paid less to the doctor? You know, and that will get a little bit dicey. But nonetheless, the doctor is a much better place for those decisions to reside than the payer, and in a not only for the quality of healthcare, but for the sustainability of a value initiative. And that's related to the second point, which is, yes, you can always game upcode, you can DRG, you can, you know, all the games that people play, well known. The difference is if you are effectively the insurance company yourself. So, you know, Mount Sinai is, I think this has been announced, is planning to become a Medicare Advantage plan as of next January. Yes, it's been announced. Okay, so if Mount Sinai is, if not, I just did. I had heard Ken Davis say it publicly, so I was okay. If you're a Medicare Advantage plan yourself, you don't have as much incentive. I mean, there are still games that can be played with regard to the selection of patients and what have you, which the payers, you know, the selection of patients into Medicare Advantage, but you have no incentive at that point to be gaming yourself with regard to the internal arrangements. So I agree with you that one should be cautious, that no previous effort has succeeded in constraining cost growth for a long period of time. But nonetheless, there are two things that I think are hopeful. One is there has been, I talked about the last 5 years, but there's actually been over a longer period of time a kind of seminal decline in the rate of excess cost growth. So with regard to the official projections, even if you use the last 10 years or 15 years rather than the last 25, you get a lower projected growth rate because there's been some deceleration. And the second is we have, I think, such opportunity to produce better value here in the United States that many other countries' attempts to do similar things are, you know, it's harder. If you've got, I'm not going to say it's right, but let's just, for the sake of argument, take the Institute of Medicine and other studies suggesting that maybe 30% of healthcare spending does not improve health outcomes in the United States, and that's the important point, in the United States. That means 5% of GDP is on the table in terms of spending that doesn't improve health outcomes, and that's a massive amount that could be worked off. In other countries, that number would be much, you know, a country that's spending 9 or 10% of GDP on healthcare is not wasting 5% of GDP on healthcare, unless it's even less efficient than us. So the opportunities for savings are also higher here than in many other countries. And by the way, I would also note one other kind of sub-themes for these changes being cyclical in the United States is if you look across other countries, Europe and Japan, there has been a deceleration abroad too. And so people say, therefore, it must be some global phenomenon. What's the global phenomenon? recession, therefore it's all cyclical. What that ignores is it's similar to the Medicaid story. There have been a lot of policy changes, especially in European countries that have been hit by hard fiscal crises, that have changed the trajectory of their spending. And so just like I wouldn't look to Medicaid as an indicator of structural change because there have been a whole variety of policy changes, the fact that the rest of the world slowed down at the same time as the United States doesn't tell me very much, just like the fact that Medicaid in the commercial space slowed down at the same time Medicare did doesn't tell me very much either. Up here.
Thank you. Thank you very much. Can you comment at all on the nature of length of stay at each phase of the continuum of care, and if that has any effect on this?
Yeah, so there's been, well, as you know, I mean, so going back to the 1980s, we were talking about DRGs a second ago, length of stay declined following the imposition or the introduction of DRGs in Medicare. What was interesting was they declined for all patients, not just for Medicare patients, because you can't really treat, oh, you're a Medicare patient, I'm going to treat you completely in a completely different system of care than for everyone else. And by the way, that's what's happening. One of the most forward-leaning, just to pause for a second, then I'll get back to your question. One of the most forward-leaning states in terms of moving to value-based payment is Massachusetts, where if the national average is 10%, through the alternative quality contract, the Blue Cross Blue Shield of Massachusetts has been driving, and some policy changes at the state level. They're probably at about 40% now. And the evidence suggests that the alternative quality contract has decelerated growth, not only for the commercial patients that are covered by the alternative quality contract, but also for Medicare patients at those hospitals. So there's spillover in the opposite direction that's occurring. And again, this is not surprising because you all know you're not going to say, oh, you're Medicare, you go into this wing, and you're going to be treated completely differently. With regard to inpatient length of stay, one of the complicating factors over the past couple years, which is very controversial, the past year or so, is the so-called 2 midnight rule, which has to do with when the length of stay that someone's required to have in order to qualify as an inpatient stay instead of an observation stay, in order to be segregated from the auditing process that has typically happened. And all I would say about that is it's a big mess right now because CMS thought they were doing, honestly, this is fascinating. CMS thought they were doing hospitals a favor. They really did. They thought we're going to simplify things, we're going to do you a favor, and without doing adequate consultation with hospitals, they just made a big muck of the 2 midnight rule and the RAC, the recovery audit stuff that has been on hold, and it needs to be cleaned up, and they're well aware of that problem. In general, we have seen a significant shift from inpatient to, as was mentioned before, ambulatory and outpatient settings, and one would anticipate that this would continue. And so that has an effect on the distribution of people who are covered by traditional length of stay calculations also. But beyond those couple observations, I don't have any, there's no great trend that I could identify that's happened over the past few years. Let's go way in the back.
Just to get back to your Washington hat.
Yeah.
And take you out
I
of
keep
New York.
trying to, but okay.
I'm sure you're trying to forget
Yeah.
it. But when you think about your 20 to 40% uncontrollable cost issue, dealing with ACOs and
Yeah.
related organizations, things that just can't be controlled right now that to some degree may be better controlled when maybe Mount Sinai is one day the size of Kaiser and we have an extensive hospital system that's much more integrated. There are other elephants in the room here in terms of costs in that 20 to 40%. And that includes things like end-of-life care, which we haven't talked about at all, which obviously is, again, one of those elephants in the room.
Yep.
And expectations on the part of the American public that aren't quite the same as, let's say, that in the EU.
Yep.
And the second is cost of drugs. I mean, is there any expectation that Washington is going to do anything to try and control that aspect of what could continue to be part of that 20 to 40% cost that we can't control?
Sure. So let's deal with both of them in turn. First, with regard to end-of-life care, one of my great frustrations, and again, this is one of the reasons why I'm blocking out much of my Washington experience. I literally had someone 2 weeks ago come up to me, and they had all of their notes and what have you, and said, you had argued forcefully for this, whatever the thing was, this thing, blah, 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 blah. And my response to that was, and all the notes and through 3 meetings and what have you, my response to that was, I'm really glad I did. That seems like it was the right stance. I have zero memory. Like, even with your reminder, I don't remember that at all. And I think that's part of the successful blocking out. But in any case, end-of-life care, one of the frustrations has been many things get politicized. If you think about requiring an advance directive or some kind of indication of what you as a patient prefer with regard to end-of-life care, you're not saying you have to do X or Y, you just have to tell us what you want. That is the ultimate consumer-driven healthcare tool, because you're requiring people to identify what they individually want. And yet, requiring that is politically disastrous, explosive, can't be done, what have you. I think the evidence is pretty compelling that not everyone chooses the high-intensity end-of-life approach voluntarily. Maybe, I think the best evidence suggests through informed decision-making, maybe a quarter or a third people say, no, I'd rather not have that. And that's a pretty big deal given the concentration of costs that we've seen at the end of life. So the fact that we can't even kind of move in that direction just suggests how politically polarizing and difficult what I consider to be entirely sensible steps. I'd also note, by the way, just one quick aside, since you had mentioned end of life, one of the other fascinating things that's been happening over the past couple of years, or not past couple of years, past couple of decades now in the United States is the mortality gradient by education and income has been exploding. So we've had a lot of discussion, this is not the topic for today, but a lot of discussion about income inequality. There's been much less discussion about life expectancy inequality, but it is massive. If you look at the life expectancy at age 65 for a college graduate male versus a high school dropout male, 1990 it was 1 year difference in terms of additional life expectancy conditional on reaching age 65. Now it's more than 6 years. I mean, just massive changes. And I know that's an aside, but I wanted to mention it anyway. What was your second question again? Oh yeah, drugs. So two things. One is it is important to realize, and I know you do, that pharmaceuticals account for somewhere between 10 and 15% of total spend. So they're not quite as large as often in the popular mind. That having been said, there's no question that there's more efficiency that can be obtained there. There's been a pretty dramatic change. If you look at the 2003 estimates of the Medicare prescription drug benefit when it was imposed and what's actually happened since then, the actual costs have been dramatically lower than what was initially projected to be. So the argument that people make that costs always turn out to be higher than was initially projected, demonstrably false for the Medicare prescription drug benefit. And the reason, some people say it's because of competition among Part D plans. The big reason is that there's been a massive shift to generics, and the pace of innovation has changed relative to what was expected at the time, and that combination has resulted in a significant reduction in the cost of Part D. Now the question is, what can we do to further, to get additional gains? And the problem is, again, it comes back to politics. Most people aren't willing to do the things that would actually work. So, one proposal is allow the Secretary of HHS to negotiate prices as part of Part D. And that sounds great, except stop and think about it. The only way the Secretary would actually have any leverage in that discussion is if she had the ability to just set the price, to just by fiat or by legislation set the price, or if she had a formulary, had some buying power behind her, had a drug plan behind her. Because most of the proposals to allow the Secretary to negotiate don't give the Secretary either of those powers. And so the Secretary would just march into a pharmaceutical firm and say, I'd really like you to reduce your price, please, and here's a lollipop. And the implicit threat is if you don't, we're going to do something nasty to you, but do we really want that to be the kind of system of government? So there's a missing piece, which is people want lower prices, for example, through Medicare on pharmaceuticals, but they're not willing to do the hard stuff, which is either have a public formulary, a public plan as part of Part D, or give the Secretary price setting authority. And so you wind up with kind of a little bit of a mush. Let's go over here. Here comes a hard one.
So an IT question for you.
Yeah.
In 1996 with HIPAA, there was a requirement for a national patient identifier system, which was never implemented. And politically, it's been difficult to do so, but at the same time, the requirements are such that institutions have to be aware what happens to a patient wherever that patient is. And at great expense, institutions and states and local institutions have to put together brick by brick what could be done in the stroke of a pen on a national level very quickly. Do you think there will ever be a move to go to a national patient identifier system?
Unlikely. We've seen, look, so there's been a lot of discussion about health information exchanges and other ways of trying to piece together data. But the thought that we'll have, let's go beyond that, the thought that we'll have like one health ID card nationally, it's hard for me to see. Again, it comes back to a polarized political environment and, you know, the fears of Big Brother and so on and so forth. I guess it is what it is. In the meanwhile, by the way, we are seeing at least some, you know, a little bit of consolidation in the EHR, EMR space with some of the major systems really kind of gathering momentum. And those systems, including the Epic one that we use here at Mount Sinai, are not perfect by any means, and they're often clunky, but there is at least, you know, a much higher share of the information that's flowing through healthcare is now digital than it was 10 years ago, and that trend will continue. So it's frustrating, it's slow, the sharing across different systems is still nowhere near what it needs to be, but it's still better than it was 10 years ago, and I think it will get better still, even though it's frustrating. Let's go way in the back.
This is actually following on Bruce's question. You credited the availability of digital information and information in general for as being very important for actually being able to determine value and outcomes. I'm curious if you see any possibility of there being too much information, if there's any danger at all in having lots of information in your mind.
Yeah, there are a couple dangers. Many of which can be at least attenuated, but yes, information overload is a real problem. For those of you who are practicing physicians, I come back to Epic, a number of hard stops and click-throughs and what have you can become, that's actually a great example. There is an optimal level of hard stops or other click-throughs because at some point you just overwhelm the physician and they just click through and don't pay any attention to what the pop-up is saying. And so there's an example of information overload. It's also well known that when presented with too much information or too many choices, people can freeze. And one of the big things about behavioral economics is trying to narrow the choices and make it somewhat simpler for people and have default rules and what have you. So there is definitely the risk of too much information in terms of information overload for physicians, if you will. On the other hand, there's also a risk with too much information in terms of overfitting and belief in models that are beyond what the capability of the models are. So if you have a massive amount of data and you're looking for correlations across different things, you're going to find them, even if those are not causal and even if they're not predictive of future activity, just because you have so many potential explanatory variables that you'll be able to find correlations there that don't actually make sense. And that, to my mind, is an example of what the folks were doing with like the 6 years of GDP growth, because I don't think it's plausible that GDP 6 years ago is affecting healthcare spending today. And that's exactly what you get when you just do the kind of kitchen sink kind of analysis, and the risks of kitchen sink analyses are exploding, especially with machine learning tools. So it used to be that the constraint in that was someone had to sit there and program all the different variables that you would be looking for correlations. Now you can literally just dump it onto an Amazon server with a whole variety, including one at Cornell, of a machine learning package that will automatically. In fact, once for fun, I have a team that was mentioned, financial strategy group at Citi, and once just for fun, using de-identified and public data, they were doing an analysis, and I, just for fun, it cost $2 or $3 to have the Amazon server, and there's a package up at Cornell that does the machine learning correlations. I dumped the same data into that, had it run all night for $5, and it found, I walked in the next morning and said, I really think you should try the third lag of the logarithm of, I don't know, I forgot what it was, and of course it was there, and they were astonished, like, how could I have discovered that? But that's garbage, and that's a big risk as we move forward, that you have to combine the data analytics with some sense of what the capability or what purpose you're using it for, or else you'll have a false degree of confidence that you've discovered something that's actually not there. So yes, there are always risks. That having been said, the thought that we can't do better, for example, on risk adjusting, but all this stuff on the clinical variation is fundamentally dependent on a credible risk adjuster. And the estimates for, in Medicare, for example, what share of 1 year ahead spending the Medicare risk adjusters explain, the answer is somewhere between 10 and 20%. So 80 to 90% of the variation is not being, and that's fundamentally because it's really claims-based. And all of you know that just having a claim for whatever, congestive heart failure, doesn't tell you very much about the actual condition of the patient in a way that a lot of the clinical information can. So like anything in life, there are costs and benefits, and there definitely are risks to too much information, but nonetheless, I think it's a helpful development if we are cognizant of those risks. Let's go up here.
Your comments about passing on risk to health plans. Do you have any concerns about the way the states and the feds are going about passing on risks to FIDA, Federally Integrated Dual Advantage Programs?
I don't have anything particular to say that would, no.
It scares me because they're passing on risk for fully capitated programs for duals in the not-too-distant future, without any stress tests of these organizations.
Yeah. Well, so this is part of, I guess, two comments. One is the great missing piece in especially Medicaid policy is as you know, $200 to $300 billion of dual spending that is generally not managed, generally not coordinated. And then the question is, what can we do about it? And there's been a lot of talk, but not that much convincing evidence on what will actually work. And then more broadly, I agree. I mean, if you're a provider and you are taking on effectively capitated payments with, it doesn't have to be in the duals, it can be just writ large, you are effectively becoming an insurance company, but without all of the protections surrounding insurance companies. And as I mentioned earlier, there are going to be a bunch of hospitals that blow up as a result because they take on more, not literally. Someone looked at me like, really? No, financially blow up because they take on too much risk that they don't have the analytical tools to handle. And in some sense, you can imagine this is already true to some degree, but too big to fail, which is a phenomenon that is associated with the financial sector, it is also a kind of clear and present danger for the hospital sector over the next decade, because if you've got a hospital that's the only hospital in 100 miles or 50 miles and it takes on a boatload of risk and then gets in a boatload of trouble, I doubt the local government or the state government's going to let it fail.
To expand on that slightly,
Yeah.
You mentioned that with your theme of the steering aircraft carrier, that Sinai's aggressively steering into the national course on this. And Kathleen mentioned clearly that the Medicare margins are no to negative, and Medicaid
Right.
margins are almost negative. Do you think that public policy is attuned enough to know how minute these margins are to understand that big healthcare systems that are really trying to change the growth curve, change the economic patterns, they need to be reinforced in a way to make it a process that can move forward properly and to avoid that kind of risk? Or do you think we're really in very, very treacherous times from a public health perspective?
I guess what I would say is it always struck me as a little odd that, Representative X from the great state of whatever on the Ways and Means Committee was effectively setting reimbursement policies for, durable medical equipment or whatever. And the thought that policymakers would go in and minutely adjust each individual lever, which is the way it's worked for 45 years now, with MedPAC occasionally coming out with these reports saying, go whack that. That strikes me as much less promising than the thought behind many of these payment changes, which is the hospital is going to know better how to wring costs out of the system without harming quality than some federal policymaker at MedPAC or on the Ways and Means Committee. And so if you can somehow shift that responsibility and make it in the hospital's financial interest to do that work, that will work a lot better than what we've traditionally done. We'll see. It's obviously, again, we're going through this transition period is a very, the analogy someone had is the last place you want to be is have one foot on the dock and one foot on the boat, and you're not sure how fast the boat's moving away from the dock. That's a very awkward place to be, and that's kind of where we are today. So that's, and I mentioned the aircraft carrier. I mean, there's a lot of belief that we're moving in that direction, but no one knows exactly how fast, whether it's bundle payment or ACOs, exactly the form. It's sort of a blob out there, and so you're like, well, let's move the boat this way because that's where the blob is, but you don't know exactly where you're going. That's a big problem. And then there was a little bit of a discussion earlier. Another big issue is how do you, even if we've gone through that tradition with regard to the external incentives, and you're in a value-based world, however defined externally, how do you then create the incentives internally for your physicians to align with that? Because right now, every place that I know at least is basically kind of saying, well, we don't really know, so we're going to keep paying docs the way we pay docs, and then we'll do a 10 or 20% carve out, and then have a bonus payment on top of it. So, which is literally the foot on boat, the boat and the dock kind of thing, the dock and the dock. Anyway, and so the question is, how does that evolve also? All of which, and we're coming back to the 20 to 40% leakage, all of which are huge problems. Nonetheless, despite all of that, despite all of those problems, which are very real, I would still rather have Ken Davis figuring out where to save money than the chairman of the Ways and Means Committee. Okay, last question. Let's go back there.
So I've had some experience. Whoa, it was loud. I've had some experience working on one statewide patient-centered medical homes program, like designing it and then having a chance to implement. And I've heard a lot of discussion about that extra risk going to hospitals, to physicians. What about the accountability of the patients? And maybe could you comment on them taking on some of the risk?
So I guess there are two different pieces to that. What's happening in the commercial space, and again, I think in the commercial space, patients are going to be much more accountable in the future than they were 10 or 15 years ago, with higher co-payments. And literally, I think it's plausible that a large, and I don't mean Sears and Darden, I mean a large iconic business roundtable kind of American household believes that's corporate America, that they move explicitly to a defined contribution plan with a private exchange at some point over the next couple of years. And once one or two iconic U.S. firms do, I think we're going to have the kind of domino effect of everyone else, because it'll become the cool thing at HR conferences, and they all kind of will mimic that. So there's going to be, as part of that, a lot more responsibility loaded onto individuals, both pros and cons of doing that, but they will have it. In Medicare, traditionally, the Medicare Advantage plans have at least a little bit more of a feel of individual responsibility. In practice, whether they do or not, is up for grabs, but at least that's the theory behind them. And I guess the final thing I would say is, it was widely predicted that because of the changes made as part of the ACA to Medicare Advantage payment rates, that we would have seen a plummeting in Medicare Advantage enrollment rates. Instead, Medicare Advantage is keeping pace at about 30% of total Medicare beneficiaries. And what's more interesting is if you look at the margin at new beneficiaries who are just becoming eligible for Medicare, they're enrolling in Medicare Advantage at like 50%. And I think it's entirely plausible that as cohorts who have lived through HMOs qualify for Medicare, that percentage of people flowing into Medicare Advantage will either stay constant or go up significantly. I don't think it's very likely that it's going to drop off the face of the earth. And then the question becomes, what are the Medicare Advantage plans themselves doing, which have a little bit more flexibility to engage consumers and kind of get them invested in their own healthcare? What are they doing? And that varies from provider to provider. Thank you again for having me, and good luck with the rest of the day.